Welcome to the Carbon Company podcast, the podcast of the W. Montague Cobb Institute. And I'm delighted to have as our guest today, Dr. Professor
Either.
Marshall Chin. Would you like to introduce yourself? Tell us a little bit about where you work, what kind of work you're doing.
Sure. And thanks for inviting me to be on this podcast, Ralph. So I'm a general internist and a health services researcher at the University of Chicago. Clinically, I see patients mostly in the outpatient setting. And so I've been there like over 30 years. So some of my patients I followed for 25, 30 years. And as I've gotten older, and my patients get older, we in some ways live life together. And it's really been a real privilege to take care of my patients. Typical patient of mine is 55-year-old African-American woman from the South Side of Chicago with diabetes and hypertension. And so I really enjoy the clinical work. I teach a variety of different things about clinical medicine. So usually I have a third-year medical student in clinic with me. And then I do a lot of health policy, health services research training, and health equity training. I've been really sort of a lifelong passion of mine has been trying to address healthcare equity. Probably a couple major reasons for that. I'm third generation Chinese American. And so it was my parents' generation that came over early 20th century for economic reasons, for a better life. And both of my parents grew up in Boston's Chinatown. They both come from big families. My mom has something like 8 siblings, my dad like 10 siblings. And there clearly was a glass ceiling or bamboo ceiling, sometimes we say, on what many of my aunts and uncles could do. My mom's side of the family was noodles. They made noodles for the different restaurants in Chinatown. And my dad's side was laundry. And so I think it was like 4 or 5 of my uncles and my grandfather all worked in the laundries, tough jobs.
Yeah.
And the vast majority of my aunts and uncles were very talented, hardworking people. But because of the discrimination of that era and onwards, this clearly was a limit on what they could do. And when I was a kid, every Saturday we would go into Boston's Chinatown to visit the extended family. And Boston's Chinatown is like a lot of the Chinatowns here in the U.S., where a lot of recent immigrants and a lot of people that have a variety of social and economic problems and oftentimes have limited English language skills. And so sort of as a kid then sort of saw up front, I guess, some of the challenges of marginalized populations. And then I think like anyone who's a clinician, whether they're a social worker, a nurse, a physician, when you start training, like within a week of hitting the clinic's awards, it's sort of obvious that the health inequities. So I have my stories, and I'm sure everyone listening to the podcast has their stories also, but they really sort of stuck with me of like, because of social, economic challenges and discrimination, racism, how it's an uphill battle for many people to live their best life.
What were the barriers to, for example, accessing higher education for you and your family, and how did you overcome them?
Well, some of it's economic, and then some of it is just, it being thought to be a possibility. My dad, for example, he was the youngest, so he was lucky in terms of probably more opportunities to the 2 youngest boys. But like his first day of high school, he was in, I think it was called something like Boston Vocational High School, where he was entering to be on the track to be a sheet metal worker. And there was one of his teachers that changed his life. That is his English teacher. So like after about a week of class as a freshman in high school, his English teacher took him aside and said, "You don't belong here," and then marched him over across the street to Boston English High School, sort of a regular traditional high school. And that became the route then to eventually going on to college. So I think if it's just not in like your family's just vision or experience of what's possible, it's not even on the radar screen.
Right, possibilities.
Yeah.
Yeah. And then the vocational school would have probably taken you down the track of trades.
Yeah, sheet metal worker. He's going to be a sheet metal worker.
Yeah.
Yeah.
Yeah. And then you ended up, where did you go to medical school?
So I was a med student at UCSF, the University of California at San Francisco.
Big difference from Boston?
They're both about the same size, and they're both beautiful coastal cities. Maybe a little more liberal in San Francisco, the politics. And then the demographics are a bit different. I think like San Francisco is a more integrated city than Boston. Boston, like Chicago, is fairly segregated regarding the neighborhoods. Clearly, there are dominant themes of certain neighborhoods in San Francisco, but overall more integrated. Large LGBTQ population in San Francisco also. So one of the interesting things about San Francisco is that there's a lot of intersectional issues in terms of the mix of different identities, whether it's like race, ethnicity, whether it's socioeconomic status, whether it's sexual orientation, gender identity. So
Yeah.
San Francisco was a very interesting place to live and then to care for patients. And I trained there too at the height of the AIDS epidemic too. So it was actually a pretty brutal time.
Mm.
My fourth year sub internship on the medicine service at the county hospital, half the patients had AIDS, and they were all going to die because basically there weren't good treatments back then. And so really a pivotal time, I think, like in terms of like some of the healthcare changes. And then
Yeah.
I guess sort of saying again, like when you have a disease where at the time you couldn't do much and where there was a stigmatized population. So this may be before your time or not, but like this is too when like there was a lot of activism that was started regarding consumers and healthcare. And for AIDS, it was that it was very slow, the drug approval process for all. And then, so there was one group called ACT UP, which was like in your face in terms of the advocacy, and actually ended up working with Tony Fauci in terms of trying to speed up some of the FDA drug approval processes. So interesting to sort of observe as a med student.
Yeah. And I think historically, that movement really contributed hugely to greater patient involvement in pushing for clinical trials, pushing for research in specific areas that were neglected.
Yeah, I think like on one hand, it's still kind of shameful that it is still so relatively recent. The whole idea about patient engagement, shared decision making, patient empowerment. So all kinds of marginalized populations by race, ethnicity, or again, like in the example we're talking about, sexual orientation, gender identity, so important for groups. It's hard for patients in general to speak up. Then if you're from a marginalized group, then extra hard. So some of these issues really are very relevant for today also.
So not only do you potentially have a smaller voice, but that voice is marginalized or invalidated or discredited in some way and not taken as seriously.
Right. So I mean, it's an issue in general for marginalized populations, both if there's a power differential, then also for marginalized populations, even of from an advantaged group. So like NMA, right? We have a lot of African American Black physicians. On one hand, privileged in some ways regarding some of the economics and some of the education and possibly other aspects also marginalized in terms of then sometimes being a very relative minority in
Yeah.
whatever they work, or few numbers and hard in terms of then like power issues and dynamics and the ability to speak up sometimes.
So we're excited about this afternoon here at NMA in Chicago. We've got this symposium on artificial intelligence in healthcare, and looking really at a lot of aspects of AI in healthcare, workforce development, patient access to clinical trials. I interviewed actually Dr. Jameson this morning about that
Mm.
and how AI can kind of democratize clinical trial access by making the information more accessible.
Mhm.
Could you tell us a little bit about what you're talking about today and what your kind of special interest is in AI? And also, I'm really intrigued to know how you kind of moved into this area.
Yeah. I guess maybe I'll start like how I got involved like in the area. So as I mentioned up front, I'm a health service researcher. So I do a lot of work looking at how can we improve the healthcare system for a variety of marginalized groups, advance health equity. So look at quality of care, look at access to care, look at the cost of care. So I'd use mixed methods research, so a combination of quantitative and qualitative methods. I'm not trained as an artificial intelligence person per se, but have a familiarity with like research and a variety of quantitative methods. And I originally got into this maybe about half a dozen years ago. That one of my colleagues who used to work at the University of Chicago was a guy named Mike Howell, who then went to Google, and he was recently appointed to be like something like the chief medical officer at Google, or some pretty high up title there at Google. And when he went there, he said, "Well, there's a bunch of colleagues that he has at Google who are putting together this paper looking at artificial intelligence and machine learning and these so-called predictive algorithms that were
Yeah.
starting to become more common, and they want to build a little more equity expertise into the team. So, would I be interested in joining their team to write this article?" And so I said, "Sure, sounds interesting." And I thought I could contribute something. And so we had a paper came out, which was a paper about like the different ways that biases can seep into these into these algorithms. And so published in the Annals of Internal Medicine, I don't know, like 8 years ago, one of the early papers of that
Hmm.
type. So it's actually been pretty widely cited because it's one of the first of that type. But it was great in terms of I learned a lot from the Google colleagues regarding, again, like these sources of biases. And again, it was a great collaboration because I could put the equity lens on these different issues and all. And
So back in the early days,
yeah. Mhm.
one of the first kind of machine learning or AI applications was predictive analytics,
Yeah.
correct? And so an example of that would be predicting which patients are going to require the most support, or predicting who are maybe going to have a readmission, that
Yeah.
kind of thing.
Yeah.
And even back at that time, those predictive analytics were found to have bias.
They probably had bias from an early stage, although it wasn't until way after the fact, like years later, where it started to just become on the radar screen that, oh, you know something? There's probably a fair number of these algorithms which are biased for a variety of reasons, whether it's the data that they were built upon, how they were developed, how they were used, a variety of different things. And it's not so much it even predicted it predated AI and machine learning. That you think about it, the same issues come up with like a standard regression model or these various clinical tools, because if you have biases in any stage of the pathway of their development, which really starts with how you're going to use them, the data that you build it upon, how you build it, and then what happens when you deploy it, and whether you see if it's doing good or bad, or if there are biases. So these actually transcend AI and machine learning. So it's a wider issue. What makes AI and machine learning particularly challenging, though, is that it's more of a black box. I feel like statistics and general statistics are fairly intuitive to people. For example, like you might have a predictor variable and then an outcome, and you might see like a line graph, a bar graph, and some relationship. Whereas the whole idea about AI or machine learning, you have a large data set, and then somehow the AI is inferring the relationship among the variables, which I think to most of us seems like a black box. What happens, which is actually one of the problems that we'll talk about here as we get
So,
to this.
because when you say black box, it means that the processes and the data is not transparent. It's not really clear how the conclusions are being made by
Right.
the process.
Right. I would say, for example, the public, and I would say that most clinicians have no idea just how prevalent these algorithms are, both either for clinical use or the business operations of systems, let alone then how valid the algorithms are or if they're biased. And then a lot of these algorithms are proprietary, so there's basically little to no incentive for the companies to be transparent. So you have these algorithms which can do a lot of good and also can do a lot of bad. But one of the issues is if we don't have a way to assess that, boy, it's a high
Mhm.
risk then for bad things happening, especially for marginalized groups who don't have power.
So those algorithms could be influencing referral of care, who gets put on what list, that kind of thing.
Yes. So you might break it down into have clinical implications and then implications in terms of the allocation of resources. So you could either, you could have either and or both in terms of good or bad clinical outcomes or basically unfair results regarding how we allocate our resources in the healthcare system.
So when you say unfair, that
Mhm.
means unethical. So
I think so.
the key thing is
Right.
how do we have processes that ensure that we have ethical processes?
Right. 'Cause I think like most physicians in practice with the principles of distributive justice, meaning we allocate our resources in proportion to the need of the patient. So, for example, I see a patient that is pretty straightforward, healthy young person. That's pretty quick and straightforward, that visit. Older person comes in with multiple comorbidities, social issues, frail, maybe they have some cognitive impairment. I know that, I need to spend more time with them and probably allocate more resources regarding referrals or social support, et cetera. And same with, in general, the whole idea about population health management in a health system that, in general, people try to so-called risk stratify patients by
Mhm.
their level of medical and social risk, and then tailor the care and tailor the allocation of resources. So those who are the most needy, that have the most medical social needs, they get more resources. Maybe they'll have a community health worker assigned them, for example, or maybe will be assigned to see like the nurse and the social worker on the team also, as opposed to someone that has less needs. But the idea ultimately that we want to improve the overall population health. And then again, it just makes sense to allocate more resources to those who have more needs. If the algorithm is built such that that doesn't follow, and it's some classic examples we're going to talk about, then you can have bad results. So, for example, like one of the most famous medical healthcare examples is the so-called Obermeyer paper in Science, where there was an algorithm development company that created an algorithm to help health plans decide which patients should qualify for these chronic disease management programs where they get more attention. This is like algorithms that were used by literally millions of patients across the country. And they found that if you were a Black patient, you had to be sicker than a white patient to qualify as being appropriate for the algorithm because of biases in the way the algorithm is developed. The issue was that they use resource utilization as a proxy for a need. The problem was, though, because in aggregate, Black patients have more problems accessing care than white patients.
Right.
They don't access care until they're later in their stage. And so at any given level of resource utilization, they're sicker.
Yep, yep. And I guess also in terms of scoring for risk,
Yeah.
there have been a number of cases of race-based medicine where scores are different depending on race.
Right.
And then race may be used as a proxy for various things, which introduces bias.
Right. So maybe the two of the most common clinical examples are the way we measured renal function, this estimated glomerular filtration rate, and then pulmonary function tests, where a race variable entered both of those equations for the kidney and lung. And then when you look back at it, it's a kind of voodoo in terms of there was not a science behind it. What it made happen in practice then was that there was overestimation of then kidney function in Black patients, which made then for something like renal organ donation, and then Black patients were late then to the organ donation list for transplant. So it had real effects then in terms of then biasing as Black patients, and then probably preventing thousands of Black patients that should have gotten kidney transplants from getting them.
And because they just never got waitlisted based on those scores.
Well, they were thought artificially to have a better renal function than they really did.
So what kind of solutions are you going to be talking about?
Yeah. So the reason why I was probably invited to be on the panel was that 2 or 3 years ago, I co-chaired a panel that was asked by the Agency for Healthcare Research and Quality and the National Institute on Minority Health and Health Disparities to come up with guiding principles for trying to address bias in algorithms. The story was that Congress has sent these agencies a letter asking them to look at this issue. And so we have this 2-year process where it's a combination of reviewing the literature, a variety of public panel sessions where experts come in and sort of inform us, and a variety of public sessions where the public can comment also, and then endless rounds of iteration of these documents. But we came up with a pretty concise paper. It's published in JAMA Network Open, I believe December of 2023, free open access. And basically there are 5 principles that we think are should be the compass here. The first is that we should think about equity issues at all of the 5 phases of the life cycle of an algorithm. The 5 phases being, first, choosing the problem the algorithm is supposed to solve. So, for example, it's one thing if we're using the algorithm to improve patient health. It's another thing, for example, if a health system is using it basically to maximize profit. So you see, the problem right away. The second step is then the data that we use to build a model upon. So, for example, a simple example would be something like if you're building a data set and you have very few minority patients in it, then your accuracy on minority population is probably going to be less than if you had a more robust population. A third aspect then is transparency and explainability, which we talked a little bit about before, of this whole black box issue. And so, especially when the biases can seep in both intentionally and unintentionally in many surreptitious ways, unless we have a transparent process where we understand for an algorithm, where did the data come from? How did you develop the algorithm? And then, once it's deployed, be able to determine, well, are we doing good or are we harming people by the algorithm? So the third one being the second one being, again, transparency, explainability. The third is then in making sure that patients and communities are actively involved in all aspects of this algorithm lifecycle. So, for example, and what happens, I think, is that patients and communities keep everyone honest, right? So if the purpose of the algorithm was to basically maximize profit, that is a problem, right? If it comes at the cost of patient outcomes. And so if the community was at the table, that would not happen. Or as we start thinking about when like how the algorithms are being used and the community thinks is appropriate and not, some of these issues too start getting very tricky regarding, you know, informed consent in some ways that like any other type of like treatment tool, you know, many of us think that patients should be aware if an algorithm is being used
Hmm.
to affect their cure in some way, and they should be told, well, and here's the validity, the level of validity of that
Yeah.
algorithm, and here's how accurate it's likely to be for you, in terms of your particular characteristics and all.
So part of that is actually for patients understanding the clinical decision process and the extent to which their physician is making a decision independently or a decision with more of an organizational influence.
Yes, yes, and I mentioned that that the prior principle was transparency and explainability. Everyone should know, be able to understand, what is being done for them or to them. If they can't understand it, it means that we haven't done a good enough job explaining it. Or if we can't explain it because of like, the black box of the algorithms, that's a problem that needs to be solved. Because again, like, you know, why should this be any different from any other type of procedure where, you would be asking, well, tell me more about the procedure, how likely is it to help me or
Yeah.
not? What is the data that you're using that to build upon?
Yeah.
Will the data, did they study people like me or not?
And what are my choices?
Yeah, what are your
What
choices?
are your choices
Yeah.
if actually the decision is being made by not a human being?
Right. Or, another question would be like, you would hope that if an algorithm is being used, it's a combination of the algorithm plus a human, and the human has the, ability to override as opposed to being some type of automatic process, which, the was it Stanley Kubrick and like Computer HAL,
Yeah.
2001 and all. So, and the fourth principle in it is like specifically identifying the fairness issues and the relative trade-offs, because oftentimes it's trade-offs. So for example, from a technical standpoint, there's a trade-off between if you're trying to maximize the accuracy of an algorithm, there's a trade-off between maximizing the accuracy if you look at the whole population versus if you want to make sure that individual subpopulations also have accurate predictive value, right? So there's a
Right.
trade-off there.
Yeah.
Or and here's one of the challenges. The the definition of the word fairness, if you talk to the technical folks, the algorithm developers, they have technical definition of fairness, which don't translate cleanly to how we think about the word fairness from an English language perspective regarding things like fairness in clinical outcomes, fairness in resource allocation, and
Yeah.
that kind of thing. So there's this language issue. So there needs to be a lot of dialogue, and so it needs to be this explicit discussion of what are we talking about with fairness, what are our choices and options that you said, and what are we trading off? Because oftentimes it's not like a magic solution here that you're weighing different options which each have their relative benefits and downsides. And we're just right now we are largely making decisions without any kind of transparency or any kind of like public discussion with patients about
Mhm.
this, which is not right. Then the last one I was going to mention is accountability, and it's really accountability of all these different stakeholders to ensuring equity. It means the people who develop the algorithms, the people who use the algorithms, such as the hospitals and clinics and whatnot, the health insurers, all these different groups, accountability. And there needs to be a combination of both. Personally, I think there needs to be a combination of both free market and regulation here. Free market in terms of creating the incentives so that it's everyone's interest to basically improve health equity, and then regulations in the sense that, unless the government has some requirements here, some of the stuff's never going to be done because it's not in like industry's interest to at least the developers to open their black box.
Mhm. Right, right. So you need a balance between the free market or uh, the opportunity to innovate and develop these solutions,
Exactly.
but at the same time having some guardrails.
Right, and you basically the political scientists, my colleagues, they've taught me this word governance, meaning like you whatever system you have, whether you're more of a free market person or more of a pro government person, you want to have the rules of the game set up in a way that is in the interest of the players to basically maximize the population's well-being and health, as opposed to profit alone. you know?
Yeah.
So right now we have a very much like sort of this neoliberal free market philosophy here with the assumption then that, what works for the free market is good for the overall. But of course, the economists know that term externalities where there are situations where the market doesn't work, of which one of the key one is then like marginalized populations without power.
Right, right, right. So in the case of in healthcare, so much is influenced by levels of health literacy.
Yeah.
So in a free market, well, it's not a free market at all because people are making decisions in different ways.
Right. Well, yeah. And also for a market to work in theory, there's got to be perfect information.
Yeah.
And healthcare is probably one of the best examples of a market that has like nowhere close to perfect information for the users.
And the field is moving incredibly quickly, as you mentioned.
Right.
Things have changed. Kind of in summary, what do you see as how things are going to evolve in the next couple of years?
Yeah. And here I'll speak a little bit to the NMA membership about this also. So you'll see like in my 3-minute overview talk today, I start off with like there's a Tom Cruise movie called Minority Report.
Mhm.
Science fiction, takes place in the future.
Great movie.
Yeah. Tom Cruise is a member of the police force of that society. And in that future era, the state has the system where they believe they can predict who's about to commit a crime. And so the whole thing is, well, when they sense the crime's coming, they alert Tom Cruise and the police force to go ahead and arrest that person. It will then be convicted and put into jail, which
And
raises the ethical
and the
question.
term is pre-crime.
Right.
It's like pre-diabetes.
Right, right. So it's an ethical issue. Can you really sort of arrest, convict, and punish someone who hasn't committed a crime, but you have predicted you're going to commit a crime? And so, the thing is, it's not just science fiction. There's a book called Weapons of Math Destruction, Math
Math.
MATH
Mhm.
Destruction, where the author, I think her name is Kathy O'Neill, goes through today, like things like the housing market, banking, education system, or like criminal justice system, and the ways that algorithms today are being used in biased ways that harm people. So one example is that some courts, some judges, in determining how long a convicted person's sentence should be, will use these predictive algorithms, which then, of course, put black men at high risk for getting longer sentences,
Right.
in a biased way. So all a long way of sort of saying that like the stakes are high, and it's like in many ways like a lot of different industries, healthcare is behind a lot of the other markets regarding addressing these issues. And we know that those other markets messed it up in terms of like bad things happening. And part of our responsibility is to not repeat the mistakes of the past. We're in a situation now too where like with the change of administration from the Biden and Trump administration, the Biden administration actually wants to do some of the regulation in terms of equity and whatnot. One of the first executive orders the Trump administration passed was to rescind the Biden order, thinking that it went overboard in terms of stifling innovation in the free market.
Mhm.
And there's also some clause there about specifically not wanting to like social engineering, in terms of like equity. And the broader context that we have here is that there's an all-out assault on equity right now. The cuts to healthcare, the cuts to the social sectors, the attack on science, censorship, and so there was this real fear, especially if we know that transparency is critical for addressing algorithm bias. If anything, the trend is to try to basically sort of censor the discussion about diversity, equity, inclusion, or try to erase inequities. There's a real danger that barriers going to be placed in terms of addressing this issue. So part of the issue is that the NMA, the membership, and the organization itself needs to think about what is its role in terms of this issue of trying to prevent bias. There's a terrific, very short article, a 2-3 page piece that came out 2 or 3 weeks ago in the Lancet. Authors are Matt Winia, Monica Peak, Michelle Heisler, where the title is something like, "What kind of criteria should we use to think about whether public health people should advocate regarding a given issue?" And they have like 7 or so criteria, which I think are useful criteria to think of, again, as individuals or NMA as an organization of like to what extent they should come out strong in terms of this issue of equity and the algorithms. And these things are things like, oh, you know, is the organization expert in this area, i.e., equity? How effective could they be? Do they have certain specific expertise? What is the risk to the organization of this? Does the public expect them to speak out on this type of issue? And I would argue that for most, if not all, these like factors, yeah, it's very much in NMA's wheelhouse and really one if an organization like NMA does not speak out about this particular issue, what organizations are in terms of trying to basically address the algorithm bias?
Yeah. And NMA is a membership organization.
Yeah.
It has a certain amount of independence because of that.
Yeah.
Which is a great strength.
Right.
Yeah. Very interesting. Very interesting. Thanks so much. I think we can link to your JAMA paper with the 5 principles.
Yeah. It'll be a free open network, JAMA network open. Yeah.
So I'll link to that in the summary.
Super.
Going out with the episode, along with information on this afternoon's symposium. And the great thing for our listeners is that the symposium will be available to stream as well as the live event, which is happening this afternoon.
Yeah, thanks so much for NMA and the Cobb Institute for holding this important symposium and panel on AI and algorithm bias. It's a critical issue. And, I'm optimistic that the NMA has traditionally been a very strong voice on issues of health equity and a very effective voice. And this is a very important issue for the NMA to be really a leader at the table on.
Dr. Marshall Chin, thank you so much.
Thank you very much.